Hey, we're back, folks. I'm your host, BKP, and it is now time for Ask the Doc. And we always want to open up and thank Northside Hospital, North Georgia Cancer Research Center, right here in Blue Ridge, affiliated with Northside Hospital. We appreciate them for bringing this great weekly update, Ask the Doc, with Dr. William Whaley. I have a question.
Yes.
Do you know the guy here?
I got to introduce.
I want to see if you know
I got
this
to
guy.
introduce my guest. My guest today is Dr. Ray Tidman, who is the founder of the Riverstone Medical Complex and the senior physician in this county, and from time to time joins me here on the couch. You see, and I'm learning that he puts my people used to accuse me that if you ask Dr. Whaley what time it is, he tells you how to build a watch. And after I've told you how to build a watch, Ray tells you what time it is. So,
and I'm right twice a day.
Yeah, right.
Yeah, but you know, out of all that, what I picked up, you're the senior guy.
Yeah, right.
Senior guy in the area.
All right, now
I don't know how to take that.
There's two things you got to tell them. One of them is we don't need a truck because it's partly cloudy.
Yes.
Second is we're up to date on rain. Third is schools are open in this county, and we don't have a snow day. And that's for everybody in the country.
That's a pretty good update.
Yeah, and for everybody in the and it's cold out there, and the weather's bad.
Schools are open.
People come to school. People come to school is what I'm trying to say.
The rain table is
exactly right. Yeah.
A little overcast. Don't need a truck.
Don't need a truck. And I don't want to. The politics of this business about going to school and the politics about the vaccines got nothing to do with cancer or blood. And we may come into that a little bit later. But you want me to go to the questions?
Yes.
All right.
We have two questions this morning.
All right, this first question, I know where it came from because we talked about IV iron blood transfusions about 4 or 5 weeks ago. It says, my wife had a gastric bypass 3 years ago and lost 200 pounds that cured her high blood pressure and her diabetes. She is 56 years old. That tells me she's after menopause, okay? And since the operation has had 2 ER visits that needed blood transfusions. And now she is being seen by a hematologist who is giving her IV iron. Well, we do that in office every day. Dr. Tidman sends us some of those patients. Her GI doctor did a colonoscopy and a stomach scope and found no bleeding site, but they all say she is losing blood from her GI system. What is going on, and what should she do? One more thing. Did the surgeon do something wrong? Well, at the end of the day, this is a pretty common question. And so I strongly believe in bariatric surgery for certain people, and one of my family members has had it. And I see all of the complications of it. But Ray's an expert in diabetes, high blood pressure. He does research on high blood pressure medicines and diabetes medicine. So who would you send, Ray, to get any kind of bariatric surgery, not necessarily a bypass?
It's a good question and a common question. Weight loss is probably one of the most common things that we deal with in primary care. Weight loss is a multi-billion-dollar industry in this country, and almost all of it's hooey. It's just nonsense. I basically talk to my patients that it's physics. You've got to burn more calories than you eat. Now, however you're going to figure that out, whether it's surgery or discipline or exercise or
training for a marathon.
It's physics. It comes down to that. So back to your question about who do I recommend surgery to. There are 3 common forms of surgery. There's the sleeve surgery, the lap band, and the bypass surgery, gastric bypass. They all have different
techniques. All right,
techniques.
well, put that first slide up because I was getting ready to show it because that shows you the 3. Put it up and everybody look at it for a few minutes and we'll pull it down. Go ahead.
So the lap band is actually, they're doing more surgery taking them out now than they're actually putting them in. The bottom line with the surgery is if you decide to go that way, you have struggled and and worked at this and probably failed at almost everything else. So it's a last choice.
Right. And you've had a psychiatrist see you.
And when you do decide to go, you will spend time with a psychiatrist.
Right. That's the rule.
Yeah.
Well, the thing about this surgery is, it used to be, you don't, if you get a facelift or an augmentation on your breast, it comes out of your pocket.
Mm-hmm.
It used to be, if you did bariatric surgery, it came out of your pocket. Mm-hmm. Medicare now pays for bariatric surgery. Excuse me, Medicaid now pays for bariatric surgery, and Medicaid doesn't pay for a lot. So that has to tell you that the cost-benefit ratio of doing a bariatric surgical procedure, even with all these complications I'm going to talk about in a minute, saves the government money when you consider diabetic complications, hypertensive complications, heart attack, and stroke.
And skeletal problems.
Yeah. So anyway, basically, let's go. Well, go ahead. So Ray's got the idea that it's a last resort for people who have had decades of fighting. I just can't do it. I've been to the nutritionist and I've done everything. I did Nutrisystems. I bought the meals at the thing.
I might add one other thing.
Yeah, go right ahead.
Because I try to get people get into low self-esteem around this. It becomes a cosmetic thing, and certainly that is a big effect. But it is, as Bill's alluding to, there are secondary diseases from this. And one of the things I try to get patients to visualize is what are they doing to their body in a real visual way. And almost everyone in the country has at some point been in a gym. And they've seen the 50-pound weights that some people put on a rack and start lifting up. So if you think about some guy carrying 50 pounds extra or 100 pounds extra.
Or 200 pounds extra.
Or 200 pounds extra. Think about trying to hold that weight all day long and you cannot put it down.
You know, I hear you have this bag.
Yes.
And I hear, wait a minute, I hear stories that if somebody may visit you, mm-hmm. you may just quietly roll over, open a little thing while you're talking, get this bag and hand it to them.
And ask them how much it weighs.
Yeah, I've heard stories.
It's a bag of sand.
I do not know this.
Yeah.
I do not know this, but I've heard stories.
Well, I mean, think about the mechanics of it. I want a patient to feel that mechanics.
You want somebody to, hey, feel this.
Yeah. I mean, if you're a pregnant lady, you're going to have back pain because you're carrying this weight out here for months. If you're a heavy guy with what I call Dunlap disease, that's when your belly Dunlapped over your belt buckle. If you've got Dunlap disease, then you're carrying that weight every day for years, and you are torquing your back, and you are going to have back pain.
And hip pain, knee pain.
And hip pain, and knees wear out, and all that kind of stuff.
I don't want to take the personal shots, but I learned really quick not to look at this guy and say, hey, doc, my feet hurt and my back hurt. I made a mistake.
All right, let's get on. All right, go to the next one here.
I know the answer you gave me.
Let's go to the next one. Possible complications. All right, just look at this quickly here. Short-term and long-term hospitalization, reoperations, infection, bleeding, or leaking at the suture stabilizer. That's the top one on here. That really is probably what's going on with this patient, is that just small amounts of iron are going out in the blood from the various suture lines. Now you can have intestinal rotations and vitamin mineral deficiencies and all sorts of stuff, and you can die. Of course, you can die from the dentist, right? All right, take that down. Now we're going to get into iron deficiency anemia, because that's what this patient has and has been transfused in the emergency room several times. That's $3,000 or $4,000 a crack when they get blood transfusions. So most of the reasons that you get blood transfusions, that you get iron deficiency, is you've got to have loss of blood on a chronic and continuing basis, or dietary inadequacy. Well, you just can't hardly have a dietary inadequacy in the United States, because the bread in the supermarket and everything else is fortified with iron. So the most common thing, if Emily was having iron deficiency, it would be probably due to menstrual cycles and stuff like that, or pregnancies. But when a male has iron deficiency and he hadn't been shot or stabbed, he hadn't had a surgical procedure, he is bleeding from his GI tract. And the question was written in such a way is that we know that this woman is old enough to not be having menstrual blood loss. So the fact that her doctors have said this has to be coming from the GI tract is the truth. And the fact that they look in the upper abdomen and they look in the colon is absolutely mandatory. Now, you're younger than Ray, but there used to be on the market triple 666 or 777 tonic, and these iron-containing tonics that they used to sell on the radio and the television said if you are fatigued, take triple S tonic it was, I guess. Well,
I think the tonic was the important thing.
Tonic was the important thing, but the tonic contained iron. And the death rate from colorectal cancer and gastric and esophageal cancer in this country was high because people who were fatigued because they were iron deficient, instead of going to their doctor and getting evaluated, were taking the triple S tonic, keeping their blood count up until the cancer was too far along to be cured. So they were removed from the market because of self-medication to get you, when you're fatigued, to go to the doctor. Well, this lady went to the doctor, didn't she? All right, so she has to, you got that thing off the screen now? So she has to be losing blood somewhere. You don't, and most frequently when we do this, you're looking for colon cancer or stomach cancer. You're looking for polyps that might bleed, or hiatal hernia or gastric. They're bleeding somewhere. So if the stomach's okay and the colon's okay, then you've got to the point where the rest of all these things have been sewed together. And you only, I use this analogy, you have to lose this much blood every day for your stool to have a positive stool blood test, but you only have to use this much blood every day to be iron deficient. In other words, there's a large gap between how much blood can be in the bowels every day and how much it takes to be detected from the stool blood test. And by taking iron, it doesn't make a difference, you take 10 iron tablets a day, you can only absorb 18 milligrams of elemental iron per day, regardless of how much you take. And that's why generally today you do not replace iron in iron deficient patients with oral iron. You do so with IV iron. Go to the next one.
You just can't catch up.
You just can't catch up. So here's this. I always like to show how fancy the algorithm is, and this is exactly where that patient told me Ray makes sense out of this. So this is the fancy algorithm, right? And so this says if you have a blood count below 15, that's really very close to normal, and your iron is less than 100, or your saturation is less than 20, then IV iron is the best way to replace it. And if you just have a little bit of extra menstrual blood loss or something and you don't get to those numbers, then taking an iron pill can keep you from getting to this point. So basically the question is, what's this all about? It's all about she's still losing blood from her stomach. Second, giving her IV iron is much cheaper than blood transfusions, and it doesn't allow her to get that sick again. And did the surgeon do something wrong? And the answer is absolutely not. 30% of patients who have this gastric surgery will have iron deficiency from chronic, very low intensity blood loss. There.
Let's put a primary care angle on this.
Well, that's what I wanted you to do.
So, you know, one of the things we talk about there, you get screened for cancer because a lot of the cancers you can't know they're there until it's too late or later than it should be. You can't feel colon cancer until it's out of the bag. So you get your screening colon cancer test. You can feel anemic. You can feel tired, exhausted. Interestingly, something Bill taught me was you're actually robbing your muscles of their iron before you're robbing your red blood cells of their iron. So by the time you're getting significantly anemic, you've already pulled a lot of iron out of your muscles, and your muscles need that iron to move oxygen in and out of those cells. So patients that are starting to get anemic can feel exhausted. Common things we talk about, colon cancer, but even more common is a bleeding ulcer. Patients running around with just burning in their stomach, and they're putting up with it, and they're chewing Tums, and they're doing all kinds of things, and they're having a steady long-term blood loss. Patients that present to the office with severe anemia, which is always amazing, like you talked about this patient, their hemoglobin's around 8. You pull their eyelid down, and it's pale. It looks pale. Their lips look pale.
Remember how your grandmama used to look at your palm and tell you, stick your tongue out? Stick your tongue out, boy. Let me see what it looks like.
So, I mean, there are visual clues that a doctor can look at. Just coming in the office, they're going to say, this person's anemic, and we've got to do a massive workup. These all come back to us being humans and our bodies being able to repair themselves. Well, as we get a little bit older, that repair is not good enough, and that's where you go to get your medical care.
Anyway, go see the doctor when you get tired. All right, next question. This is kind of a complicated question with a short answer, I think. My wife had an operation on a nodule on her scalp that was diagnosed as a sarcoma, and the doctor did a huge operation to get it all. He did lots of scans and said it was okay to watch. I Googled sarcoma, and it scared me to death. What should we do? This is a question that sometimes I tell people to keep off the internet. Show that first one. So if you go and Google sarcoma, the first thing that pops up is going to say sarcoma of soft tissues. Pop up that next picture that shows them. And this scalp, you got the scalp lesion there? This lesion on the scalp that really looks ugly there is a poorly differentiated skin sarcoma that's not a joke. It's got 40% recurrence rates. But that sarcoma that he's talking about, scalp nodule sarcoma, you go to what you find when you Google. This is so rare that you can't Google it. All right? It is such a small percentage of sarcomas that when you Google it, you come up with this. Now, you remember one of the kidney kids had his leg taken off when he was 12? That's osteogenic sarcoma. We had, I forgot who somebody recently had a brain sarcoma. Every one of these has got real terrible survival rates if you don't do really great surgery. And this has got that guy just scared to death. So
rare as hen's teeth.
Well, in all my practice of 50 years, I've seen 2. All right, so show that next thing here.
So, are you talking about the last 50 years or the first 50 years?
Yeah, right. So in 50 years of practice, I've seen 2.
Yeah, that was for you.
So I always like to show one of these. And put that up there. You see that survival, there's 2 little survival curves there. Or you take that back down. Those survival curves represent what this doctor did. He did a huge operation to get it all. That's the top line. So he went back and he made sure he had 2 centimeters, 2.5 centimeters is an inch, so 2 centimeters is darn close to an inch, of clean tissue all around it. And he went all the way down to the bone at the bottom, and he made sure that those margins were totally clear. And if there was any question, then they went back and they radiated the scalp. Then they'd end up like Ray, because you can't grow any more hair. But if you do those 2 things, then your survival rates are like that. 80% survival rates forever. If the guy didn't go back and get it all, or he didn't radiate it if the margins were clear, it's 40% survival out at 10 or 15 years. So that doctor has done the right thing. There ain't nothing else to do. You shouldn't be scared. And yes, you're going to need to go back from time to time to be evaluated again by more scans and just make sure it doesn't come back locally. So don't panic because it's a sarcoma, and don't let that internet fool you. Now, that's going to get me into the news of the day, okay? And it's going to get me into COVID vaccine. Have you looked at the news in the last 2 or 3 days?
Yes.
Okay. Germany approved one of our vaccines that we are using in this country for people under the age of 65. And we are giving it to people over the age of 65. Second, big thing in the news today. What's the name of that vaccine anyway? Novavax vaccine is not effective against the South African variant. We just got through saying last week, I showed you why our vaccines are good against the new variant things that are coming. Third one was that the World Health Organization and the CDC have opposite advice about immunizing pregnant women. World Health Organization says no. American scientists say talk to your doctor about it and make your own decision, but there are no theoretical reasons not to immunize pregnant women because this is a dead virus. And we immunize pregnant women with flu and everything else all the time. So what I'm trying to say here is that let me get you to look at this one. There are right this minute 90 something, what's the number? There are 67 vaccines in clinical trial. You look at that?
Yes.
2 are approved for use, and that's our Moderna and our Pfizer.
Yeah.
4 have been abandoned. 8 of them are in limited worldwide use and been approved first one place and then another. Okay? So you have 67 vaccines out there that are undergoing clinical trials, and 2 have concluded those clinical trials. So the news is making like Germany's saying this vaccine's not any good. What Germany said was, we've had it done in 30,000 people or 15,000 people in Germany, and we're not through analyzing the data yet. That's number one. So it's not that the vaccine's not effective. Somebody's seizing on the fact that they're still in the evaluation phase and are emphasizing something that hasn't been concluded yet. We've already said we haven't tested this vaccine in people under the age of 18. Is it 18 or 21?
18,
anyway,
yeah.
18 or 21. Well, they're testing it in the pregnant women, but they haven't finished. So you can't say with 40,000 pregnant women have gotten the vaccine, but nothing adverse has occurred in the ones that are getting it experimentally, and we give vaccines exactly like this all day, every day to pregnant women, and there's not any reason not to. So the fact that the World Health Organization isn't happy with it yet, and our scientists are, the news is making like it's a tragedy. So it's just, to me, like going back to school and the vaccine. And the COVID virus. I got a kid that's in the Catholic school, going to full-time school, wrestling and playing football. And the state of California says when we open up, we're not going to allow them to wrestle. I'm crying tonight. Anyway, that whole thing about the vaccine, I think the press is making people uncomfortable by seizing on little pieces of information that are true, but they don't mean anything, and blowing it all out of proportion. Now, can you make some sense out of what I just said?
Let me put a different angle on that.
Please.
But I first want to make the point, or keep emphasizing the point, of these economic shutdowns. The people who are forcing these economic shutdowns around the country still, or around the world, are dancing with stupid. Okay, that's all I need to say. Frequently in medicine, or in any field of analysis, you try to look at things from different angles. And Bill has given you the vaccine biopharmaceutical top-down look. We do research, we test, and we roll it out once we have enough established safety factors and efficacy factors. So that's the top-down view, and that's what you get in the news, because the pharmaceutical companies are looking at it from that angle. If you look at it from a different angle, and that is that there's a lot of fear out there in the public, whatever reason, however it got seeded, it's out there. So if I look at it from that angle, I try to talk to my patients, because that's their point of view, in 2 different lines. There's 2 extremes. There's the at-risk patients, what we've called through this broadcast all along the fine china. over 65, more than 2 comorbid problems, the target's on your back. Okay, you're still going to survive this, but you're in the high risk. Then there's the under 20. Really doesn't affect them, affects them less than flu. Okay, so that age group does not need this vaccine right now. It's unproven, and they don't get sick from it. So from their point of view, why should I take something that we don't really know enough about and expose myself to any risk? You see what I'm saying? Any risk. Whereas you look at the risk benefit in that older age group, the benefit of the vaccine far exceeds the risk. The risk has been studied, and you're going to benefit more from that vaccine, and you really should consider getting it. And then between those two groups, you have those that really, well, first of all of those people need to make up their own mind. They don't need to have somebody else tell them what to do. So they make up their own mind, decide what they're going to do. But all those people in the middle, it really is a questioning yourself thing. If you've got multiple comorbid problems, if you're diabetic, hypertensive, overweight, inactive, recently ill.
45% of our country is overweight.
Yeah. So if you're in that group, then you have to judge for yourself. Well, I'm hearing it's pretty safe, and I've got some risk factors, and probably ain't going to hurt me, so maybe I should get the vaccine. Maybe not. But that's the group that's in question, not the extremes. So that's really where I try to focus on my folks. My older folks come in, and I'm like, yeah, get in line. Call every place around here. Get your name on the list when they call you. Yeah, when they call you, go in there and get it. Which whoever calls you first, get it done. But all those people in the middle, I really just say, no, pay attention, listen to what you're hearing out there. If you got the risk factors, as soon as it's available to you, I would consider getting it. I've had the vaccine, and I'm fine.
Point is, Ray, it's not going to be available to them for a long time. And we are getting more and more information that there is no group that shouldn't take the vaccine because it is not a live virus. It's only an RNA, and there is no medical contraindication or potential contraindication. The stuff about affecting your DNA or affecting your reproduction, all that is all much BS. So what do you call them, the conspiracy theorists and all the reasons why they shouldn't be touching it, there's no fact or even close to fact behind it. What Ray was talking about the fine china and the comorbid conditions. Now, I'm going to just focus on this county, and I reviewed all the county deaths that have occurred in this county, and there have been a bunch of them. And I've picked the patients that are over 90 years of age. So of the last 6 in this county that were over 90 years of age, did they have comorbid conditions? Well, relative, of course. 2 of them had no linked comorbid conditions. The other ones had 2 to 6 comorbid conditions. So even in the people that are over age 90 that are dying, it's mostly over age 90 with something else. Well, I mean, I've got high blood pressure and atrial fibrillation and everything else, so I've got technically comorbid conditions, I guess. But in today's newspaper, it says that the New York deaths in the nursing homes were underestimated by 40%.
Yes.
And I believe that to be true. This is killing people in nursing homes. Now, we all know somebody local who wasn't in a nursing home. 2 of my patients have died of COVID virus that didn't have a bunch of comorbid conditions except they were over 80 years old. But the point, once again, is it's a real serious disease in this group of people. Mm-hmm. Now, we know people in this county that we know well that are 50 that have almost died from it, but that's the smallest number. And there really is no reason for anybody that's 65 or over not to go get the vaccine. And we have bone marrow transplant patients, chemotherapy patients, all of our patients, we want that vaccine regardless of whether they're getting immunotherapy, chemotherapy, bone marrow transplant, everything else.
And age. I mean, those people, if they, you want them
as early as they can get it. Now, what we tell them is, you're not going to respond to this vaccine as well as somebody else because you're actively on chemotherapy or whatever, but you will respond to it. And that degree of response will protect you to some degree, not 95%. But we want you to get that vaccine immediately.
One other risk factor, it always falls out of my mind, and I'm glad you said that, Bill. We don't have a lot of it here, but you have a lot of it in urban areas. People living in tight, packed living conditions. Well, a nursing home's obvious. Assisted living's obvious. Those people are close together. If you're in an immigrant community and you've got 2 or 3 families living in the same house, you're pretty packed in. You got an elderly person in that house, they're really, that's as high risk as diabetics and obesity.
Maybe worse.
and probably worse because you're really spreading that virus in that house. And so that's another thing to keep in mind, is that if you're in a fairly tight living condition. One other thing about that middle class of people is even if you're fairly healthy and you're a caretaker to a very elderly person, you're in and out of their house, mom and dad or a neighbor that you check on all the time.
Or you work with them.
Or like my staff, or young staff, they're around COVID patients regularly or elderly patients. I ask them to get vaccinated early. Same thing if you've got one of those folks that you're the caretaker for, I'll go out of my way to figure out how to get you the vaccine. We can ask that people younger than 65 get the vaccine for indication.
So if you're working somewhere, because I have one question, because we have our panel ready to go over here, but I have one question. But if you're working somewhere and you're not in the health factor, risk factor, age area that you should be getting the vaccine, but when you go home in the evening, mom moved in with you. Dad died a couple years ago. Mom moved in with you, and you're taking care of mom. You should tell somebody that, because you're out in the day, you're working, stopping at the store, whatever. You should try to get that vaccine because you're going home wherever you're at and you're taking it in where mom's at. You should try to tell people that that's important.
Your engineers are young.
Yes.
And they work around people with risk factors.
I get it.
So your engineers that are with you hours of every day and up close, and the people in your office that are around you every day should be vaccinated.
Got it.
And that is, now, when Ray's talking about people that are 30 years old and they work on construction sites with 30 years old and they live in a house with 30 years old and some young kids, maybe they don't need it. But just about everybody out there,
they should be the last in line.
Yeah, but just about everybody out there is face to face with people that are older on a day-to-day basis. I want to, before we expert panel don't have anything to say today. There's nothing going on in politics. The news of the week, I already hit several of them about the vaccine, but you always hear it here first. Vitamin D may help fight COVID-19. When did I say that first on this program? April. Come on now, that's 9 months ago, and you heard it here first.
Leading edge.
Now that
vitamin
guy,
D?
Vitamin D.
I'm a vitamin D kind of guy.
That guy that told you, that you hear it here first. You got the COVID, you got the Zika here first.
Okay, so here's the question. I've got to ask this.
All right.
Okay, have to ask it. So the media out there, because there's always something going on throughout the week that I keep up with what the media is telling viewers throughout the week.
We've tried to beat them over the head today, haven't we?
Right. So we had Thanksgiving, and the health officials came out and the media came out that we should not be having these Thanksgiving super spreader events. And then after Thanksgiving, they claimed that we went up because we had to get together and travel get together.
Christmas.
Then we had Christmas, and they're blaming super spreader. Now, this week in the media, they're giving their Super Bowl party advice. So would you guys like to get in on Super Bowl party advice?
Yeah, why don't they just shut up?
Well, did you notice that
Could you elaborate?
Can we elaborate on that? I mean, you need to go about our lives. We've got a vaccine out there. We're now vaccinating people faster than they're being put in hospitals. Okay, so we're ahead of the game. Do all the things that we've talked about doing, but go back to life. Go back and be a normal human.
All right, Ray, read the headline of the first one in the news. What did it say?
COVID-19 cases fell 34% in the last 2 weeks.
34%.
Loud.
U.S. COVID-19 cases fell 34% in the last 2 weeks.
All right, now, Super Bowl party. the Tampa mayor last night signed an executive order that outdoors in Tampa
That said it's Tom Brady's last one?
Between now,
Oh, okay.
between now and 9 days after the Super Bowl, everybody on that 3-mile walk, river walk there, and in any public place in Tampa must wear a mask. So that's aimed at 22,000 people who are going to be there instead of 400,000 like usually come to a Super Bowl. And it's the government telling people outdoors like this, beautiful sunshine in Florida, that you've got to wear a mask if you're out of doors. Now, if you're out of doors in a place with 50 people, wear the mask. But that means some guy that's out there on that river walk jogging, which I've done many times, would have to wear a mask.
Yeah, you don't need to be wearing a mask jogging. Sorry.
No. Anyway, it drives me crazy.
Stay alive, go outside. Okay,
Yeah.
I got one other important thing.
We
before
got to close. I got the panel. Go
Okay,
ahead.
well,
One
it's
more.
just my teaching point. How do you know when you've reached middle age?
Okay, how do you know? I feel like, how do you know when you've reached middle age?
When you finally get your head together and your body starts falling apart.
Hey, folks, we're gonna wrap this because I feel like we could go on and
All
on.
right, my closing comment
he has
is
a closing.
get the vaccine and donate blood.
Get the vaccine, donate blood, make your doctor's appointment. Your health care, very important. Don't let anything happen. Make your doctor's appointment. BKP here. Thank you very much, North Georgia Cancer Research Center. Thank you, Northside Hospital, for this, affiliated with Northside Hospital, this segment every week. If you have a question for Dr. Whaley, send that to info, I-N-F-O, at FetchYourNews.com. You can send that, put Ask the Doc. You can find our social media. Ask Dr. Whaley a question. If you want to share these segments with family and friend, go to FYNTV.com. That's that simple. At the top, you'll see Ask the Doc. You click on there. All of the segments are there. Or our YouTube channel, Fetch Your News, FYNTV, Ask the Doc. Thank you, Dr. Tidman.
You haven't been kicked off YouTube for the rest of your life?
Not yet. We're monitoring that daily.
We do know somebody that was.
Do you?
Yes. President Trump.
Yes, President Trump. All-star political panel, as I always say. I wonder if they have something to talk about as soon as we return.